the possibility of using anticoagulation on our patients. As already published by the heredity registry regarding to the bleeding, myocardial infarction and stroke in dialysis patients for more than 200,000 patients in this registry, it was shown that as a cause of death in dialysis patients, bleeding will increase the mortality, also the myocardial infarction and stroke as thrombotic events. And this was increased especially for patients with dialysis comparing to general population. And as you see here, especially for bleeding, it was increased by 6.2 per 1,000 person years among dialysis patients, regarding to only 0.3 per 1,000 person year in general population. It is interesting that when we're looking for the coagulation cascade and processes, I will not spend time on this, but just look for this intrinsic and extrinsic pathway and using the activation of factor 10, and factor 10 is a key factor for this cascade. The factor 10 will activate prothrombin to thrombin 2A and then activate fibrin to make fibrin clot and thrombosis. It is interesting also to know that neurosacquired hemostatic abnormalities have been also identified in renal insufficiency, especially regarding to the alteration in platelet function. Secondly, to the alteration of platelet vessel wall interaction, and finally to the enhancing role of bleeding by the intensity of the anemia in CKD patients. Also, we have some therapy that contribute to the increased risk of bleeding in CKD patients. Not only this, but also CKD patients are also subject to clot formation and increase of development of thrombosis, as we know that pulmonary embolism is more frequent in dialysis patients. Vascular access thrombosis also is much more important, especially also when we have a PTFE graft more than a native arteriovenous fistula. And we know that there is a high prevalence of systemic, and this is due, to the high prevalence of systemic inflammation in CKD patients, but also diffuse endothelial damage, activation of platelet and monocytes, reduced antithrombin level activity, deficiency in anticoagulant protein C and S, and also alteration of the activated protein C with the resistance to it. And it is interesting to note that these abnormalities are also reversible, and as it was published in this paper, for 16 patients with hypercoagulable states on hemodialysis therapy and who underwent renal transplantation, author share with us that deficiencies in protein C, S, antithrombin 3, and resistant to protein C were completely corrected by kidney transplantation and normalization of renal function. So these are reversible. But the problem also for our patient is not only these problems found in CKD patients, but patients on hemodialysis also are subject to activation of the coagulation cascade, especially due to the plasmatic coagulation activation, the cellular coagulation activation, especially by the platelet activation, but also leukocytes and platelet coaggregation and tissue factors, so stimulation, and finally by other factors such as the slow blood flow, the high hematocrit, but also the blood transfusion in the extracorporeal circuit. And I emphasize especially the problem of the use of dialyzer and the contact by the blood to the membrane, but also the arterial and venous bubble traps, which are two parts of the extracorporeal circuits where the clotting is very easily formated or initiated. To control this clot formation in hemodialysis, we use anticoagulation, and we can classify the anticoagulation in depending on their chemical composition or their inhibition of the clotting cascade, and directly or also by the target within the clotting cascade, which is the more used. And we have the indirect agents increasing the activity of the natural inhibitors, such as heparin and heparinoids, and the direct thrombin inhibitors that block thrombin, and finally the citrate that can act also as an anticoagulation in our patients. This is an overview of all the anticoagulants we can use in our patients. We have, of course, unfractionated heparin and low molecular heparin, but also the direct thrombin inhibitor, the heparinoid, the citrate, and other, especially the prostacyclin that we can use also when we have a problem with the heparins. You can have these slides, of course. It's up to you if you like to have the slides after the session. Which is interesting to note now, which is important and which is better for you to use unfractionated heparin or low molecular weight. This is the big debate in the literature. I don't know if you use unfractionated heparin or low molecular weight heparin. Who use unfractionated heparin? Who use low molecular weight heparin? Most of you. Because you think that low molecular heparin is more efficacious? Or it is less expensive? It is less expensive, low molecular heparin, than heparin. Yeah. Yeah. It is not on all the countries. For example, in Tunisia, where I come from, heparin is much much less expensive than low molecular weight heparin. So we choose to use heparin, for example, and fractionated heparin. The problem is the debate still open because unfractionated heparin especially inhibit the thrombin and the factor 10. Otherwise, the low molecular weight heparin predominantly inhibits factor 10. Otherwise, it's not specific. And the problem of long molecular weight heparin is that longer half-life, more than 4 hours for most of all the low molecular heparin. Otherwise, the short half-life of unfractionated heparin is very interesting to note in this field. What is also interesting to note is that the low molecular weight heparin, we use it because maybe it have the best bioavailability at low doses, less non-specific binding to endothelium, macrophages, platelet, plasma protein, and so on. The dose is independent. We have a dose-independent clearance. The longer half-life for use in hemodialysis patients is not a good thing, I think. The more predictable anticoagulant response, the single fillet syringe injection, and this is the choice of the low molecular heparin we take. Also, there is no monitoring required for return healthy, of course, outpatients. So when we look for the debate and we ask some mentors in this domain, as Andrew Davenport, he said that unfractionated heparin is the anticoagulant of choice, and this is for many years. Otherwise, the trend is attributable to the ease of convenience, and the administration of low molecular heparin make the more low molecular heparin mostly used nowadays. What about guidelines? And the guidelines we have from European Society is from 2002. And it said that the advantage, as mentioned in guidelines, that major study shows in the improvement of lipid profile with low molecular weight heparin, and especially for reducing or less increase in reducing, the dense LDL, I mean LDL 5 and 6, and that's have an anti-atherogenic effect. Also, the low molecular heparin increase less hyperpotassium comparing to unfractionated heparin related to the aldosterone inhibition with unfractionated heparin, which is dose dependent also. And low molecular heparin reduce aldosterone up to 30% less than unfractionated heparin. And also, the osteoporosis also as mentioned, and maybe the unfractionated, the low molecular weight heparin have many advantages regarding to the heparin. But also for the heparin-induced thrombocytopenia, the HIT, we have to think of course, for our patients, but there is an advantage for, and it is believed that low molecular heparin is less likely to form such a reaction because the complex with the long chain of saccharides is minimal with low molecular heparin than it is with unfractionated heparin. Please look here for the fondaparinux, for example, there is no possibility to have the interaction, so it is safely used in HIT. What about the studies now? And this is, I will show you two reviews regarding to the comparison between low molecular weight heparin and unfractionated heparin. Regarding to the bleeding, there is no difference in this meta-analysis, but the advantage is especially regarding to the transfusion requirement, which is less with low molecular heparin regarding to the unfractionated heparin use. Also, if you look for the vascular compression time, it is the same. If you look for the extracorporeal thrombosis, it is the same. So there is no difference out of blood transfusion in this meta-analysis. This is another systemic review and meta-analysis more recently published. And they find the same result regarding to bleeding, no difference in the bleeding. So there is no difference for bleeding between unfractionated heparin and low molecular heparin. Otherwise, there is some advantage for lipid profile for total cholesterol and triglyceride, but not for LDL cholesterol, and maybe, as I showed you before, improving the quality of the LDL cholesterol, reducing the low and dense LDL cholesterol 5 and 6, which are very heterogeneous for our patients. For the osteoporosis, there is no study evaluated the incidence of osteoporotic fractures said in this meta-analysis. Otherwise, two studies measured the osteoprotegerin, and the Rankin level, and there is no significant difference between low molecular weight heparin and unfractionated heparin. And one study evaluated the bone marrow density and bone mineral density, and there is no difference also in this study, and there is some decrease switching to a low molecular weight heparin, and the mean bone mineral density in the same region decreased by 238% after the patient were back to the unfractionated heparin. So there is some advantage for low molecular heparin, but it is not significant. Otherwise, for the thrombocytopenia, one study reported no thrombocytopenia in this meta-analysis, and for the other, nothing was announced regarding to the thrombocytopenia. For the hyperkalemia, it was not studied in this meta-analysis. So the conclusion of the authors that low molecular weight heparin showed to be at least as safe as unfractionated heparin for extra-circuit anticoagulation in chronic hemodialysis, and there is no difference noted in this meta-analysis too. What about the Cochrane meta-analysis? And the Cochrane meta-analysis was announced in 2015, but no results up to now, no publication, only this abstract in the Heredity 2018, I think. And in their conclusion, the evidence for anticoagulation drugs hemodialysis during hemodialysis is of very low certainty, and as trials have not been designated to measure important clinical outcomes. So there is two other considerations when using low molecular weight heparins. The first is regarding to the half-life and the selectivity. Of course, for example, enoxaparin is more selective for factor 10A than tenzaparin, for example. But when we look for the half-life of enoxaparin is 24 hours, regarding to the tenzaparin 5 hours. And for hemodialysis, we don't need such a long half-life, so it is more interesting to use tanzaparin, for example, than enoxaparin for our patients. The second one is the venous administration and the arterial administration, and we have to look for especially arterial administration, since if we do it on the venous in the venous line, we have an increase in anti-10 activity. So we have usually to use it at the same site injection, which is artery. What about the guidelines for the recent guidelines for the UK Renal Association? And in their guidelines, they announced that anticoagulation without added risk of bleeding, we should use even unfractionated heparin or low molecular heparin to reduce the risk of clotting. Heparin, we can use it as a loading dose followed by continuous infusion. And it is discontinued 30 minutes before the end of dialysis, and low molecular weight heparin is an alternative. So they privilege heparin, unfractionated heparin. So it is an alternative agent that has been associated with a lower risk of bleeding, less frequent episodes of hyperkalemia, and improved lipid profile compared to standard heparin. Otherwise, when we look for the meta-analysis, we don't seem to understand that in their results. Otherwise, there is no difference in the incidence of bleeding complication, it was said in these guidelines. Also, for patients with significant risk of bleeding, we should use systemic anticoagulation, kept to a minimum dose. Otherwise, we should avoid anticoagulation if the risk of bleeding is life-threatening. And unfractionated heparin may be used with caution in patients with intermediate risk of bleeding, but at low dose. The proposition also to use regional citrate anticoagulation for this patient, and I think this is a nice possibility in our patient with a risk of bleeding, since it is a regional anticoagulation only. For the anticoagulation in patients with HIT, type 2 and HITs, and now in this case, we don't have to use heparin, and we can use the heparin with, especially for the danaparoid, for example. We can use it for our patient, otherwise it is very expensive, and I think in Africa we don't have it. I don't know if you have it or not. Of course, in Tunisia we don't have it, so we have to use only dialysis without heparin with flushing, saline flushing, and we use also sometimes the citrate anticoagulation as a regional anticoagulation. So if you have, why not, direct thrombin inhibitors or heparinoid, and if you don't have it, you can use citrate regional citrate anticoagulation. We use it, but we used at that time because this is an old study. We use acetate dialysate, not bicarbonate, because the problem using citrate is the alkalosis and hypocalcemia. And as you see, when you use acetate as a dialysate, we don't have, it is very effective, as you see here, it is very effective for the regional anticoagulation, but also we don't have an increase in serum bicarbonate, otherwise we start a little bit low, and we don't have problem of hypocalcemia in our patients. So it is safely used using acetate, but now we don't have acetate, and we have bicarbonate, and if you use bicarbonate also it is possible, but the risk is especially hypocalcemia, hypomagnesemia, but also citrate toxicity, especially for patients with hepatic failure and the problem of metabolic alkalosis for these patients. We can use citrate as a maintaining dose without loading dose, and the monitoring is we use the post-dialyzer ionized calcium 0.2 through 0.3 millimole per liter, of course, to inhibit the citrate activity. And it is well used without any problem, and it is very it is not expensive, and we can use it without any problem. Lastly, we have the use of citrate dialysate, since we can replace acetate by citrate in the dialysate using 0.8 millimole of citrate. And there is no additional calcium needed. By reducing the dialyzer membrane fouling, it has been reported to improve dialyzer clearance also. And however, the serum magnesium values might decline if the dialysate with a low level of magnesium is utilized. So usually we think about checking the magnesium and the correct hypomagnesium in these patients. The reports of citrate dialysate permitting anticoagulation, anticoagulant-free hemodialysis is published, and it is true. Use it in the center where I work now, and we can have dialysis without use of anticoagulant when we use citrate dialysate. Otherwise, additional but reduced dose of anticoagulant are frequently used for these patients. What about if patients have already anticoagulation or anticoagulation? What we have to do? The conclusion of this study comparing no additional anticoagulation versus low dose of dalteparin with patients with antivitamin K, and they show that there is a benefit for using to avoid clotting heparin. And the conclusion of this study is that they are able to demonstrate that standard oral anticoagulation with an ENR between 2 and 3 alone will not prevent clotting during dialysis. So we have to use anticoagulation with heparin for these patients. But we don't know if the ENR is between 3 and 3.5, if we have to use or not such anticoagulation for the extracorporeal circuit. Most of our patients can have atrial fibrillation. And for that, do you think that using antivitamin K is very useful and can protect patients from stroke? This is a meta-analysis showing that there is only one study which is positive. There are many studies without benefit, and one study with harm, or 2 studies with harm, especially for elderly patients. So I don't think that antivitamin K is interesting in our patients. I'm not a cardiologist, but cardiologists usually ask us to use antivitamin K. Otherwise, you'd have to remember that antivitamin K have many problems, more than the problem of bleeding. The first cause of mortality in our dialysis center is bleeding, due to especially antivitamin K. And the arterial calcification also is induced by the vitamin K antagonist, arterial stiffness also, left ventricular hypertrophy, and especially calciphylaxis. I saw in the 2 last year 3 calciphylaxis, and the 3 are on antivitamin K. What about the new oral anticoagulant? When we look for dialysis, not to use, not to use, not to use, not to use, so we can't use this medication in our patients. Otherwise, in the USA, it is possible to use apicapsaban. And when we look for the apicapsaban and we look for the US renal data system, and we look for the major bleeding, we see that with the direct oral anticoagulation and comparing to heparin, there is a benefit for this direct oral anticoagulation, means apicapsaban. And finally, do you think that the use of aspirin as an antiplatelet for our patients can prevent from ischemic stroke? This study and this meta-analysis also show us that it's very beneficial to prevent especially myocardial infarction and stroke. This is for stroke, and to prevent stroke. Otherwise, myocardial infarction, stroke, and cardiovascular death, and the reduction is about 40%. Otherwise, this is balanced by the risk of bleeding. And if you apply this result to SHARP trial, treating 1,000 dialysis patients with vascular disease with aspirin for 5 years. This is projected to prevent 16 ischemic strokes, 75 myocardial infarction or revascularization. Otherwise, it had 19 intracranial bleeds and 53 serious extracranial bleeds. So to conclude, dear colleagues, and the take-home messages is that the CKD 5D is a population at high risk of bleeding and thrombosis, and this is multifactorial. The anticoagulation is needed to avoid clotting of dialyzer and extracorporeal circuit, especially for bleeding, and fractionated heparin equal to low molecular heparin. Lipid profile, maybe there is a benefit for low molecular weight heparin. We don't know for the consequences for the major atherosclerotic events. For the HIT, maybe there is some benefit for unfractionated heparin. Sorry, it must be the inverse. Otherwise, if we have HIT, we have not to use unfractionated nor low molecular heparin. For the osteoporosis, maybe there is some benefit, especially, sorry also for the mistake, there is some benefit for the low molecular heparin, but no supporting clinical data. And for hyperkalemia also, there is some benefit for low molecular heparin, but no supporting data too. Maybe for the cost, this is a possible point of choice between the two, and the simplicity, which is usually in favor of low molecular weight heparin. If we have HIT, we use the naparoid especially, but the cost is very important. The alternative is use of regional citrate anticoagulation. For the hemodialysis-free anticoagulation is possible with citrate dialysate, but we have to use a high blood flow rate, and maybe we can use the saline regular flushing of the extracorporeal circuit if we can't use citrate dialysate. Otherwise, if warfarin was used, it still needs the use of heparin at a lower dose, maybe 50% of the dose. For the CKD 5D, 5 hemodialysis atrial fibrillation patient, the use of antivitamin K is less efficacy than in non-hemodialysis patients. Maybe we have to look for the treatment to range, that it should be more than 70%. And also we can look for the side effect of these molecules, arterial calcification, stiffness calcification also, calciphylaxis. The direct oral anticoagulation is not to use in our patients, only in the USA, which is possible to use. And with the retrospective cohort data, there is less major bleeding, so it is a hope for our patients. And finally, for the CKD 5 HD atheromatous patients, antiplatelet therapy should be used because we have a prevention of stroke, myocardial infarction, and cardiovascular death. Otherwise, it is balanced by the increase of major bleeding. Thank you for your attention.